Well, good morning and welcome to Sunday Morning Coffee with Dr. Childress here. So, today I want to discuss exposing the pathology of a factitious disorder imposed on another. Um, a diagnosis of a false pathology, a factitious disorder, is a diagnosis by rule out. It's ruling out authentic causes and then you're left with only one possible explanation. It's a false pathology. So I'll be discussing that here today. Starting with just the overall general differential diagnosis that we're concerned about in the family courts. When there's a child rejecting a parent, a child is seeking to flee a parent, uh, that's a directional change in the attachment motivation. That's caused by child abuse range parenting by one parent or the other. And that's the important feature to understand about the diagnosis of FDIA, a factitious disorder imposed on another, is that one parent or the other is causing the child's severe attachment pathology. Either it's an authentic attachment pathology that's being caused by the abusive range parenting of the targeted parent. Okay, and that's what the child's symptoms would seem to indicate, the child seeking to flee a parent. That's caused by abusive range parenting by that parent. So that would be an authentic attachment pathology. It's pathology, it's not normal, it's not healthy, but it's authentic in that it's being caused by the abusive parenting of the targeted parent. Or it's a false attachment pathology. The targeted parent is not abusing the child, it is a persecutory delusion and false attachment pathology being created in the child for secondary gain to the allied parent. So that's the differential diagnosis here. Is it a true or false attachment pathology? So the first set of uh, diagnostic possibilities is that the targeted parent is authentically abusing the child, in which case it's child physical abuse, child sexual abuse, child neglect, or child psychological abuse. We should diagnose what type of abuse the child is being exposed to that's causing the child to want to flee that parent, and then put it on a treatment plan and fix it. The alternative diagnosis, though, is if the targeted parent is not abusing the child, so it's not an authentic attachment pathology, then it is a false or factitious attachment pathology imposed on the child for secondary gain to the parent. It's also, there's a delusional disorder involved in that, in producing the false pathology. They're creating a shared persecutory delusion. And either one of those or both of those diagnoses, a shared delusion or factitious disorder, is a child psychological abuse diagnosis. And there's considerations in the overall diagnostic picture here of possible spousal psychological abuse of the targeted parent by the allied parent using the child as the weapon. So the pathology that I'll be talking about today, the diagnosis, is that particular FDIA, the factitious attachment pathology, and how to identify that in the family. So the first thing in diagnosing anything is to look at the diagnostic criteria. And so we are going to apply this diagnostic criteria to the symptoms and to the situation. So from the ICD-11, which is from the World Health Organization, it's a diagnostic system that has the code number for all medical and psychiatric diagnoses. So this is the big book of diagnoses. It pretty much lines up with the DSM-5. And so for the ICD-11 diagnosis 6D51 FDIA, in the DSM-5, it's 300.19. And this is what they say. This is a criteria. Factitious disorder imposed on another is characterized by feigning, falsifying, or inducing medical, psychological, or behavioral signs and symptoms or injury in another person, most commonly a child dependent, associated with identified deception. So to apply that first diagnostic criteria, The allied parent is inducing psychological and behavioral symptoms in the child, uh, child dependent, in order to deceive the court and the mental health people about the nature of the parenting of the targeted parent. The target parent's a normal range parent, but by creating these severe attachment symptoms in the child, they are deceiving everybody about the parenting of, and they're saying, "Oh, they're an abusive parent." No, they're not. They're a normal range parent. And so that's the first criteria. So yeah, it meets that criteria. The second criteria here is the individual seeks treatment for the other person or otherwise presents him or her as ill, injured, or impaired based on the feigned, falsified, or induced symptoms. So again, we apply that diagnostic criteria. The allied parent is seeking treatment or court orders for protection for the child, and presents the child as being injured by the parenting of the targeted parent. It's an abusive parent, and the child needs to be protected from that parent based on the induced signs and symptoms, the false attachment pathology that's being created in the child. So there's your diagnostic criteria. It meets diagnostic criteria for producing. Now, in classical FDIA, back in Munchausen days, when I was trained up in it in Children's Hospital and stuff, there was another aspect to the DSM diagnosis called secondary gain. What were the rewards to the parent for producing the false pathology? So we had both of producing the false pathology, this part, and also identifying what the rewards were, secondary gain to the parent from doing that was. But DSM, American Psychiatric Association, doesn't like internal motivations as diagnostic criteria. So they've dropped that criteria from the diagnosis. However, clinical psychologist I like that component of identifying what secondary gain is involved. And in the family courts, there's three possible secondary gain to the allied parent for producing the false pathology in the child. First is to deceive and manipulate the court's decisions around child custody. The second is spousal abuse of the targeted parent by the allied parent using the child and the child's induced symptoms as the weapons of spousal abuse. And the third is to meet that parent's own emotional and psychological needs. They're using the child as a regulatory object to meet their own needs. So we have three strongly considered secondary gain rewards to the allied parent for producing pathology in the child. And that becomes important on treatment as we work to remove those motivations, those rewards for that parent in producing pathology in the child. Diagnosis guides treatment. So now talking about the diagnosis specifically, though, of FDIA, because it's a false pathology, it's a diagnosis by ruling out authentic causes. So if you think about medical FDIA, the child's coming in with vague symptoms of a medical disorder. And so the doctors have to figure out, the physicians have to figure out, is this an authentic medical disorder? And if it's not, if they've ruled out all the authentic possible medical disorders, then it's a false factitious disorder, and they call up a pediatric psychologist to assist on that diagnosis. But as a pediatric psychologist diagnosing FDIA at something like Children's Hospital, I require that the physicians tell me that there's no authentic medical cause. The moment they tell me that, I can diagnose the FDIA. So a factitious disorder is a false, artificially created set of symptoms with no authentic underlying cause. And when we look to identify or diagnose the cause of the symptoms, there's nothing there. There is no cause because it's not a real pathology. It's a false induced pathology by the parent. So diagnosing FDIA involves ruling out any real cause. And if there is no real cause, then it must be a false pathology. Either it's a true pathology and there's a true cause, or it's a false pathology and it's a factitious disorder, one way or the other. So here's the linear logical line of reasoning on the diagnosis. Now, let me say something about this to begin with. Okay. The patient should never have to explain the pathology to the doctor. Okay. The doctor should already know. The doctor should be explaining the pathology to the patient. Okay. So, first off, if you have to explain the pathology to the doctor, and you do, that indicates how incredibly bad that doctor is, and which is the current state of the mental health system in the family courts. The forensic psychologists are just incredibly awful, and you have to explain the pathology to them, to the doctor. So now that's deeply unfortunate. I'm working to elevate the level of standards of practice in the surrounding doctors. But until we get there, you still have a family and children who need the diagnosis of child abuse because you need to protect them from the abusive other parent. So what you're going to need to do kind of is handhold your mental health professional, your therapist, your reunification therapist, or your custody evaluator, or who's ever involved in the mental health side, and walk them through the linear logical reasoning and symptoms to reach the diagnosis of an FDIA. And it's pretty clear. It is so incredibly clear once you follow the logical reasoning on the diagnosis of an FDIA. So you shouldn't be having to do this, okay, over here, but you do. Okay, so here we go. First, you rule out the allegations of abusive parenting by the targeted parent. So that's ruling out a true attachment pathology. And for this, I recommend you use the Parenting Practices Rating Scale. It's up on my website. It's 4 categories: abusive range, severely problematic, normal range, problematic, and healthy normal range, and a whole bunch of different categories underneath. You ask them to rate your parenting. Is it normal range, level 3 or 4, or is it abusive range, level 1 and 2? And so we get clear indication of what your parenting is, and we put it on a treatment plan if we need to, or we rule it out because it's normal range. And so when the parenting of the targeted parent has been ruled out as the cause, level 3 or 4 on the Parenting Practices Rating Scale, then it is not an authentic attachment pathology being caused by the parenting of that parent. And it is instead a false attachment pathology being imposed on the child. Okay. So if it's not a true attachment pathology, then it is a false attachment pathology. Now, what the ignorant, incompetent forensic psychologists and reunification therapists do is they get to the first half of that understanding. And so you, after they've worked with you or assessed you, you can say, am I doing something that is abusive? And they say, no, you're not. That's not an abusive. And force them into that. Say, what's the diagnosis? If physical abuse, sexual abuse, neglect abuse, or psychological abuse? Fourth one. What? Tell me and diagnose it. If I'm being abusive, make a diagnosis. Make them say, no, you're not being abusive. The moment you get them to say that, and the Parenting Practices Rating Scale is great on that. Ask them, okay, then tell me, where am I in this? And at worst, they're going to say you're at level 3. There's some problems with you. You're a little too, controlling, but it's normal range on that. The moment they put you normal range, then it is not a true attachment pathology. Your child seeking to flee a normal range parent. That's not authentic. That's not how the attachment system works. Children don't flee normal range parents. They flee abusive parents. So it's a symptom display as if you're abusive, and you're not. It's a false symptom display. So once you get them to acknowledge that you are not abusive, that's when you kind of have to take their hand and take them to the next step in the logic and say, that means it's a false attachment pathology being imposed on the child by the other parent, right? And they said, well, I know it's either true or false. It's either a true attachment or it's a false one. And so you have to kind of help them over that logical hurdle in the situation. So, so you first rule out the allegations of the abusive range parenting by the targeted parent. Use a parenting practices rating scale, and when you're normal and average, that means the other parent is a false pathology. The other parent's the one that's abusing the child. So now I recommend these two instruments I've developed from my knowledge and understanding, and I've given you checklists. If you just check off whether these symptoms are present or absent, and whether these features are present or absent, you will diagnose the pathology accurately 100% of the time. And so for the FDIA, the factitious disorder component of the pathology, that's diagnosed by the parenting practices rating scale. And it's a diagnosis by rule out. So if you're normal range, it's not a true pathology. So it must be a factitious or false pathology being imposed on the child for secondary gain to the parent. The other location, though, is it's also on the child symptoms, the diagnostic checklist. It's diagnostic indicator 1, attachment system towards a normal range parent. And so a diagnostic indicator 1 is the factitious disorder diagnostic symptom. Okay, is the child rejecting a normal range parent? How do we define normal range? The parenting practices rating scale. Okay, so is a parent normal range? Yes. Well, then now we can apply diagnostic criteria 1. Then we get the FDIA. The shared delusion is diagnostic indicator 3 on the diagnostic checklist. That's, does the child have a persecutory delusion towards a normal range parent? So, so if you just complete these two, or get your mental health person to complete these two, the diagnosis is evident. It will be. And here's the thing. Here's the thing. If you don't believe me, if you don't agree with me, you think I'm wrong, just try it. Go ahead, try it. Just collect these symptoms. All you mental health people, every mental health person involved, the individual child therapist, the family therapist, the custody evaluator, whoever you are, mental health person involved with this family, just take 2 minutes, complete the diagnostic checklist, 12 associated clinical signs, and the parenting practices rating scale. Just document up the symptoms. What are they? Then look at that symptom set. It's going to be one or, if those symptoms are present, it's the pathology. There's only one explanation for that. There's only one explanation for a false attachment pathology displayed toward a normal range parent with a delusional disorder, with 5 narcissistic traits displayed by the child, or phobic anxiety. There's only one thing causing that. Then you add 6 or 8 of the associated clinical signs, which are by the research in these families and associated. There's only one explanation. And so if you don't believe me, just try it. Just try it for 2 minutes and see what happens. See what happens. If you start using these two instruments to document symptoms, the problem in the family courts will be solved. It's going to solve. There it is. There's your solution right there. Do that. But right now, the mental health people are saying, no, I'm not going to document the child's symptoms. You've got the worst psychologists imaginable. They won't even tell you what the child's symptoms are. And you have to handhold them through the diagnosis, and you have to explain the pathology. You have the worst psychologists ever. And so my question to you, all you parents, is why are you accepting that? Don't worry about, oh, we're trying to get this parental alienation in the, DSM. It's in the DSM. It's a factitious disorder. It's a shared delusion. It's in the DSM. You don't have to get new forms of made up pathology into the DSM. What are you doing? You don't need to go to your legislator and talk about 50-50 custody and all, presumption. No, you need to go to your legislators and say, why aren't our licensing boards in this state giving us competent psychologists? Why do I have to explain the pathology? Why are they telling me no when I ask them the symptoms? Why are they not giving a diagnosis of the family? Why aren't you expecting competence from your mental health people? So drives me crazy. So, factitious disorder imposed on another. True, false is incredibly important for a factitious disorder. Is it true disorder, or is it a false set of symptoms induced in the child by the parent? If it is not a true, authentic attachment pathology, then it is a false, factitious attachment pathology. Okay. I just want to stop at that point to emphasize that basic issue. If it is not an authentic attachment pathology caused by abusive range parenting by the targeted parent, if so, identify it, then it is a false attachment pathology imposed on the child by the parenting of the allied parent, because it's one or the other. Okay, that's logic. That's diagnosis, and then you apply the diagnostic criteria to the family. Is it true? So you got these allegations being made that the targeted parent is abusing the child in some way, allegations by the child's symptoms in and of themselves, and perhaps verbally by the child and verbally by the allied parent. So are those allegations true? Step one, rule out abusive range parenting by the targeted parent. And when there are only two possible causes, okay, and one of those is ruled out as a cause, then we only have one possible cause remaining. That's how the diagnosis of a factitious disorder is made. There's going to be the child coming in with medical issues. There's going to be medical symptoms. They will report medical symptoms. But when we go to diagnose the cause, there is no cause. It's not an authentic. So the child comes in with symptoms of, abuse and pathogenic parenting by the targeted parent. When we go look at the targeted parent, they're a normal range parent. But it's a false, factitious attachment pathology. Now, this becomes kind of important because diagnosis guides treatment. And so if the allied parent is the one who's psychologically abusing the child, creating a factitious attachment pathology imposed on the child, then my recommended treatment for that would be a contingent visitation schedule for a variety of reasons. I described this at the American Psychological Association recently. I have the same APA presentation up on YouTube, so you can watch the presentation about the custody contingent visitation schedule. Now, that is for the treatment, the contingent visitation of a factitious attachment pathology imposed on the child. Because when the child says, oh, the targeted parent is abusing me during the contingent visitation schedule, we're going to say, no, they're not. We've assessed it's normal range. It's a normal range mom or dad. So we're going to discount the child's allegations of, oh, I'm being malevolently treated in some way. No, you're not. We've assessed the situation. And we're confident in our FDIA diagnosis. Now, if it is true, authentic child abuse, that is exactly the wrong thing to do. We do not discount the child's symptoms of child abuse, wanting to flee a parent and saying that parent's abusing me, if that parent is abusing them. That is the wrong thing to do. Okay? So the critical issue. So we don't do it for physical abuse. We don't do it for abuse. So the critical issue is, what's the diagnosis? Which parent is abusing the child? Because we need that answer to make treatment decisions about the child and the family. Diagnosis guides treatment. And currently, we are not getting any diagnosis out of the mental health people, because they're so phenomenally bad. So, simple. Throughout all of healthcare, all your physicians, all your doctors, everywhere in healthcare, diagnosis guides treatment. The treatment for cancer is different than the treatment for diabetes. So, what is the diagnosis? It is that simple. And it is so simple. However, there are people, forensic psychologists with names, who are intentionally disabling the mental health response to the pathology in the family courts for their own personal, financial, and career status gain. Because the moment they solve this, the moment they switch over to diagnostic assessment and start saying, oh, it's FDIA and child psychological abuse, they admit they haven't been doing that this entire time. And the moment that we switch to clinical diagnostic assessments that can be returned in 4 to 6 weeks for a lot less money, and get a second opinion on it, the moment we switch to clinical diagnostic, their whole field of forensic custody evaluations disappears. So their whole career vanishes, and they don't do clinical diagnostic assessments. I've misdiagnosed the pathology for 40 years or 20 years or however long they've been here. So they don't have a role in the family courts anymore. And so they don't want that, because there are various positions of power, positions of their whole career, and their financial status. That's how they make their car payment, their house payment. So right now, there is a tremendous conflict of interest within professional psychology with the forensic psychologists in power and their failed experiment of forensic custody evaluations, New York Blue Ribbon Commission. And so they're looking to cover up their failure and to hold on to their jobs, their careers in the family courts as incompetent psychologists. We need a diagnostic assessment of the family 100% of the time, because we need to know what to do. Which parent's abusing the child? This is child abuse by one parent or the other. We need a diagnostic assessment. And it's simple. For any diagnosis is a pattern match of the diagnostic criteria to the symptoms. You take the diagnostic criteria, like I described in the ICD-11, and you apply them to the symptoms. If they match, if there's a pattern match, that's the diagnosis. So if your symptoms pattern match to the symptoms for schizophrenia, that's your diagnosis, schizophrenia, whether you like it or not. If you pattern match to this diagnostic criteria for schizophrenia, you've got schizophrenia. If you pattern match to a factitious disorder imposed on another, guess what? That's a pattern match. Delusion, persecutory delusion. If you pattern match to the features of a persecutory thought disorder, yep, you got a persecutory thought disorder. So the first step in making a diagnosis is to document the symptoms. What are the symptoms? You identify the potential diagnoses that could be relevant, and then you apply the various diagnoses to the symptoms. But you start by identifying the symptoms. That's the parenting practices rating scale for the targeted parent, and the diagnostic checklist for pathogenic parenting for the child's symptoms. And if you identify those two things, easy peasy, 3 minutes, just identify the symptoms. you will accurately diagnose the pathology in the family courts 100% of the time. And you will have a clear documentation for all the mental health people to talk about. And they can argue about whether or not a symptom is present or not, but it provides clarity. And it will solve your situation in the family courts. And try it. Just try it and see what happens. You will solve your situation in family courts. So with that, I'm going to head off to my Sunday, and we'll talk about some other aspect of the family court pathology next week. So good luck, everybody. Take care out there.